Ladies and gentlemen, we are now entering session 1, first session. In this session, we will explore the latest strategies and progress toward malaria elimination. And I am pleased to introduce our moderator for session 1, Professor Dr. Elsa Herdiana Murhandarwati, Doctor of Philosophy, Universitas Gadjah Mada, Indonesia, who will be guiding us through the discussion. A brief introduction about her, ladies and gentlemen. Prof. Elsa Herdiana is the head of Parasitology Department at the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Indonesia. She is also the leader of Malaria Working Group here at the Center for Tropical Medicine, Faculty of Medicine, Public Health and Nursing, UM. She is also the coordinator of Good Clinical Laboratory Practice Training, Center for Tropical Medicine, Public Health and Nursing, and she's also the principal investigator of Apple Migrant, improving malaria surveillance at cross-border of Indonesia and Timor-Leste in 2022 to 2024. Without further ado, ladies and gentlemen, please welcome Professor Elsa Herdiana Murhandarwati. Prof. Elsa, good morning.
Good morning, Mbak Karisma. Thank you for introducing me.
Thank you. It's our honor. The screen is yours, Prof. Elsa.
Yeah, thank you. Good morning, everyone, and welcome to session 1, Advances in Malaria Control and Elimination. I'm honored to serve you as the moderator for this very important sessions as part of World Mosquito Day 2025 under the theme Combating Malaria and Dengue Innovation and Strategies. As we know, fight against malaria has made great progress over the years, but many challenges still remain. Today, we are privileged to hear from 3 distinguished speakers, Dr. Inke, Nadia, Prof. Ayodhia Pitaloka, and also Dr. Indra Vythilingam, who will share their insight and experiences on topics that are shaping the future of malaria control and eliminations. So in these sessions, we will explore a range of novel interventions, including recent development in chemotherapies, malaria vaccine development, and strategies to tackle vector control challenges, particularly those related to non-human primate malaria. Each speaker will have 15 minutes for their presentation, and we encourage you to post your question in the Q&A box throughout this session. Kindly include your name, institution, and indicate which speaker your question is addressed to. We will take up the question after all presentations are complete. Now, let's begin session 1 with our first speaker. So it's my pleasure to introduce Dr. Inke Nadia Diniyanti Lubis, spesialis anak Ph.D. She is a pediatrician and tropical medicine expert from Universitas Sumatera Utara. And Dr. Inke has extensive experience in clinical and research work related to malaria. And today, will be presenting on the topic of malaria chemotherapy, an area that remains central to effective disease management and control. So, Dr. Inke, hello, Dr. Inke.
Morning, Professor.
You ready for the presentation?
Yes, thank you very much.
Okay, the floor is yours, Dr. Inke.
Thank you. Let me share my screen. And thank you so much for the kind introduction. One moment. Okay. Hope that everyone can see the slides now. So thank you again for the invitation for me to share about the new chemotherapies used for advancing malaria control and elimination in this exciting webinar today. So this in this session, I will the outlines of my talks. I will start with malaria control and intervention, although like most of them have been explained by Dr. Ajib, but I will also focus more on the chemotherapy that are being used as the first guideline for malaria treatment, which is artemisinin and also artemisinin combination therapies and the emergence of artemisinin resistance. And I think a more recent um, finding about the use of transmission block drug to control malaria. So eliminating malaria presents a complex challenge as the epidemiological profile is constantly shifting, marked by periods of declines and resurgence. And therefore, the strategy for optimizing control intervention in a country or region should be based on data from the local settings and also the endemicity of the regions. And there is no single intervention can effectively eliminate malaria, especially in high transmission setting, as explained earlier by Dr. Ajib. And we also need effective and efficient scale-up of a package of interventions depending on the malaria transmission intensity. And malaria is preventable and also treatable. There are different control measures that can be used to prevent and also to prevent the infection, but also to prevent of malaria to become severe disease. This includes the insecticide-treated nets, insecticide spraying, and also chemoprevention, which includes here IPTP, or intermittent preventive therapy in pregnancy, perennial malaria chemoprophylaxis, seasonal malaria chemoprevention, post-discharge malaria chemoprevention, and mass drug administration. And vaccine have also been included in malaria prevention strategies, especially in high endemic malaria areas, and have shown a significant reduction in clinical malaria and severe malaria occurrences. The other approaches is to enable like prompt diagnosis to enable early detection and also the availability of effective treatment using the artemisinin combination therapy. So for the purpose of malaria control and interventions, like what we would like to do is to prevent from the non-infected person to become infected. Here, what we use is like factor control, and as I mentioned, like the intermittent preventive therapy in pregnancy, chemoprophylaxis, and also vaccine. But for someone who has already become infected, we want to prevent the person to become severe or to die from the disease. So these the measures that we need here is the early diagnosis, appropriate treatment, referral when necessary, and also hospital-based management, and also vaccine to prevent the severe diseases. And I will focus on the two areas today, like on the chemotherapies and also the ACTs, not only to prevent transmission, but also to treat the disease. So as we see here in the above figure, we see these are the anti-malarials that are available all this time. So there are not so many available anti-malarials, and if we see actually the effective anti-malarial become very limited at the moment. And the ideal drug should be highly effective, fast-acting, safe, including in pregnancy and children, can be used both orally and parenterally. It should also be administered short course, stable, and also cheap. So artemisinin is one drug that has been used and has been recommended in the past 20 years. And it is actually derived from Artemisia annua and was discovered about 50 years ago. And it acts against all Plasmodium species and effective also not only for the asexual stages, but also to the sexual stage. And it can also clear the ring stage parasites, and very potent that it can clear and decrease the parasite density up to 10,000-fold within the first 48 hours. So to prevent the emergence of resistance, artemisinin is now combined with a partner drug with a longer half-life to ensure clearance of the remaining parasites and also to prevent development of resistance. This is from our experience where the previous anti-malarial developed resistance very quickly after it was first introduced or deployed in the guidelines. And there are several ACDs that are being recommended by the WHO as the first-line treatments. And here You can see 6 different combination of artemisinin combination therapies recommended for treatment of uncomplicated Plasmodium falciparum malaria. So the recommendation are vary between countries, but most common use ACTs are the dihydroartemisinin piperacin and also artemisinin. Unfortunately, in the past few years in Southeast Asia, there is an emergence threat of Plasmodium falciparum resistance to artemisinin and also its partner drug, as evidenced by a slower parasite clearance, as evidenced by increased day 3 positivity. So as we know, like when we give treatment, when we administer treatment for malaria, the evaluation of parasite density should be done 24 hours, and artemisinin is highly potent, so it should clear the parasite within the 48 hours. But when we see an increase of day 3 positivity, it should be a notification there might be a reduced sensitivity of the artemisinin to the Plasmodium falciparum parasite. The other evidence is also the increased proportion of recrudescence at day 42, because this is the coverage of the partner drug given together with the artemisinin. So in the right figure, this is the Greater Mekong area in Southeast Asia, where the emergence of artemisinin-resistant parasite have been identified since 2007. So we can see initially up to 2002, the combination of artesunate mefloquine and dihydroartemisinin piperacin were very effective in only small numbers, less than 5% of treatment failure was reported. But artemisinin has been used in this area for over 3 decades. So it has been used as a single treatment to treat malaria for over 30 years. So the parasites in the Greater Mekong, they have been exposed to artemisinin for a longer period of time compared to other countries in the world. And we can see, like, over time, the increase of treatment failures, as seen by the proportion of recrudescence increase. And in 2011, the proportion of treatment failure in several areas in the Greater Mekong is up to 50%. So what can contribute to these treatment failures, and what could promote the development of artemisinin resistance? This includes the drug administration, because the history of monotherapy in the region, and also the fake or substandard drugs, and also incomplete course and a dosing regimen. There is also the parasite factors, including the resistance to the partner drug. When the partner drug is not effective anymore, it cannot clear the remaining parasites that were not clear with the artemisinin during the first 3 days. Hyperparastemia can also promote artemisinin resistance, and also the genetic background of the parasite. Lower immunity in low malaria transmission areas can also cause treatment failures and also promote artemisinin resistance. And in low transmission areas, also usually dominate by single clone infections. So there is less competition, that makes the parasite are more common to be exposed and induce resistance, and also the higher proportion of symptomatic infections. And the last factor includes the nutritional state and immunosuppression. So how can we detect if there is any artemisinin resistant emergence in our areas? Generally, we would identify there is a resistance when we see cases of treatment failure in the population or in among patients. And this can be identified, as mentioned earlier, by the increased number of proportion of day 3 positivity by microscopy, and also like the numbers of recrudescence at day 28 or day 42, depending on the ACT that are being used. But this is actually too late, so we need a tool that can identify before the resistant parasites spread into the population and can cause more devastating impact. So the mutation in the Plasmodium falciparum KELS13 has been identified as a tool to predict the decreased sensitivity of Plasmodium falciparum parasite to artemisinin. So when there is a mutation from the position 441 at the PF KELS13 gene, it can predict of a likely resistance to the artemisinin in the Plasmodium falciparum parasite. So we know now that the K13 mutation as the marker for artemisinin resistance, and it has been reported not only in the Greater Mekong region, where certain mutated positions are highly circulated, but they are not in other areas in Asia and Africa. The mutations are not all associated with treatment failures. There are new hotspots in East Africa, like Rwanda, Uganda, and Tanzania. And this is very concerning because malaria is very endemic in these areas. But until today, partner drugs still play a big role in determining whether the ACD would fail and whether the artemisinin-resistant parasites would become widespread. And ACDs still work in most places, but we need to do routine molecular surveillance, and of course, new therapies are urgently needed. And how about in Indonesia? So these are a compilation of drug efficacy studies across Indonesia since the deployment of the artemisinin combination therapies in 2004. So we started with the use of artesunate amodiaquine in Western Indonesia in 2004. But for East Indonesia, the dihydroartemisinin piperacin was recommended. Only in 2012, like the DHP was recommended for both Western and Eastern Indonesia. But luckily, for dihydroartemisinin piperacin, all clinical studies have shown that the treatment failures is below 10%, which is the cutoff set up by the WHO to replace the anti-malarial recommendation. But for the artesunate amodiaquine represented by the red color, we see even only after a year of the deployment of the artesunate amodiaquine in Indonesia, the treatment failure was already high. And this was due to there was a cross resistance between chloroquine and the partner drug of amodiaquine that cause treatment failures of combination of artesunate amodiaquine. So several studies have also evaluated the presence of the PF-KEL13 mutations in Indonesia. So although several mutations have been reported with low proportion, but no mutation has been associated with any phenotypic failure. So it's not associated with decreased sensitivity of the artemisinin to falciparum parasite and also to artemisinin resistance. And no parasite clearance delay was found among samples with this PF-K13 polymorphism. And let's talk about the impact of artemisinin or ACDs against the sexual stages of falciparum parasite. So one study evaluated 6 randomized trials and to look how the ACDs would impact the gametocyte of the falciparum parasite. So these studies demonstrate that gametocytemia among ACD-treated patients is significantly lower than in individuals treated with non-artemisinin antimalarials. In this case, it was like the chloroquine and also the sulfadoxine pyrimethamine. So the proportion of gametocyte at day 28 was much lower among individuals treated with ACD. ACD treatment is also associated with the reduced human-to-mosquito transmission, both among those with microscopically detectable gametocytes and also several selected patients. So it seems that ACD appear to destroy a substantial proportion of immature developing gametocytes while sequestered in the microvasculature, resulting in a significant reduction in the release of mature gametocytes into the peripheral blood. So treatment with ACD also reduce infectiousness of individual patients and therefore can enhance the impact of ACD on transmission. So is the current control measures enough to control malaria and to further reduce the incidence of malaria to achieve the malaria elimination as our goal? So the current interventions targeting the factors such as the long-lasting insecticide-treated nets or indoor residual spraying might be the cornerstone and has been successfully reduced the malaria burden globally. But here we can see actually between 2015 until today, the malaria case incidences have been stagnant. And with the scale up of ACD, there is a great concern over the development of partial artemisinin resistance and also the resistance to the partner drug. So we need a new therapeutic intervention to aid in the ongoing fight against malaria, and additional factor control tools are also needed. So in the past decade, like a study on ivermectin and its effectiveness against mosquito, especially on Anopheles, have been evaluated. Ivermectin is a broad-spectrum antiparasitic insecticide, which is able to kill mosquito that feeds on humans who receive the drug. And it has also been used for different diseases such as onchocerciasis and lymphatic filariasis, and billions of doses have been given that shows excellent safety profile. And when implemented as mass treatment, ivermectin might reduce factor survival and consequently, of course, malaria treatment. But the duration of the protection is dose dependent. But the benefits of using the ivermectin, it can target the mosquitoes that are resistant to the insecticide and also targets malaria factors regardless of the biting patterns that also were not killed using the insecticide treated nets or indoor residual spraying. So initially, a study in Kenya, the Ivermel trial, reported lethality in factors 28 days after dosing of 300 micrograms for 3 days with only few adverse events. So after a dose of ivermectin, blood levels remain mosquitocidal for several days. And the Anopheles feeding on the individuals, the treated individuals, they die sooner and lay fewer eggs and lowering transmission potential. And so the laboratory studies have consistently shown that ivermectin dose blood is toxic to malaria factors at a variety of doses for at least 7 days. So like during the first 7 days, those mosquito feed on the treated human would die from the ivermectin. And follow-up studies, which is the first cluster randomized trial designed to test whether the MDA of ivermectin and dihydroartemisinin and piperacin can reduce malaria in settings where the control intervention is established already. So 3 rounds of MDA, which is given once per month of ivermectin and dihydroartemisinin and piperacin were given during 2 malaria transmission seasons, and 32 villages were enrolled. And the primary outcome was the malaria prevalence. And when evaluated, the malaria prevalence in the control group was 12.8%. And also in the intervention group is much lower at 5.1%. That concludes that MDA of ivermectin and the DHP can significantly reduce malaria prevalence and incidence in this study. Another follow-up study, which much larger, is a study in Kenya, which is a cluster of household areas that were randomly assigned to 1-to-1 ratio and received MDA of ivermectin or albendazole as a control. Again, here among children of 5 to 15 years were tested for malaria infection monthly for 6 months. And the primary outcome was the cumulative incidence of malaria infection. So in this study, 6 months after the first round of treatment, the incidence of malaria infection was 2.2 per child year at risk in the ivermectin group, with higher in the albendazole group. And the study showed there were 26% of lower incidence of malaria infection in the ivermectin group than albendazole. And also safety profile was excellent. But the last study, a Matamol study, which is also evaluating ivermectin with dihydroartemisinin and piperacin, and in a cluster randomized control trial, and 24 clusters were randomized to receive 1-to-1 of ivermectin with MDA, ivermectin with DHP or DHP with placebo. And the primary outcome was the quantitative PCR prevalence of the Plasmodium falciparum in all age group. But the study was unable to show the benefits of giving the ivermectin on top of the DHP to reduce the malaria prevalence assessed by the PCR for Plasmodium falciparum. And the anopheline parity rate was also similar between the control and the intervention group. So the study concluded that adding ivermectin to DHP had no additional benefit on reducing the malaria prevalence. So as a summary, yes, ACDs artemisinin have been used for 4 decades, and it remains the antimalarial class of choice. But there is an increased emergence of artemisinin and also the partner drug resistant, which is a public health emergency. But despite the decreasing efficacy of ACDs, especially in the Greater Mekong subregion, ACDs remain sensitive. But for ivermectin can reduce the mosquito survival and boost potential transmission capacity. Several trial results have shown some benefit, but one study found no additional benefit, and it could be determined by the dose, frequency, community coverage, factor, feeding habits, and settings. And I think that's it for my presentation. Thank you so much, and I would give this back to the moderator, Prof. Elsa.
Thank you, Dr. Inke. Please applause for Dr. Inke. Thank you for the insightful presentation on malaria chemotherapy. Now we know that we have SCT and also on trial as the ivermectin and maybe the combinations. Now it's all pleasures to introduce our second speaker, Professor Ayodhia Pitaloka Pasaribu. Prof. Ayodhia, are you with?
Yes, hi, Prof. Elsa.
Hello.
Good morning.
Good morning, Prof. Ayodhia. So, Prof. Ayodhia is a pediatrician and also expert in tropical medicine from Universitas Sumatera Utara, and she has been actively involved in both clinical and academic work related to infectious disease. And today she will presenting on the topic on malaria vaccine development. It's also an important component in global fight towards malaria eliminations. So we are honored to have her with us today. Prof. Ayodhia, you ready?
Yes.
Yeah, the Zoom is yours.
Okay. Thank you, Prof. Elsa. Let me share my screen first. Okay. Yeah, is it okay now?
Yes.
Yeah, okay. Thank you, Prof. Elsa. Good morning, everyone. Thank you for having me here. I would like to thank Dr. Inke from USU and also Prof. Egy, Prof. Elsa, and UGM team for the invitation. Following Dr. Inke presentation on the prevention, today I would like also to share the updates on malaria vaccine development. Malaria remains a major cause of child morbidity and mortality, especially in Africa. We know that more than 90% of malaria globally focus in Africa, and more than 432,000 child deaths occur in Africa due to malaria. And malaria become major cause of pediatric hospitalization and death. And of course, this will impact it on the economies, community, and also families. What about malaria situation in 2020 currently? This is the situation from 2023. Nearly about 80% of our district already declared malaria free, and around 90% of Indonesian population already live in malaria-free areas. We have very significant reduction of malaria before 2014. However, we face some stagnant afterwards, indicating that the malaria control has reached its most difficult stage in reducing cases of malaria in high-risk areas such as eastern part of Indonesia and Papua, and maintaining cases in free area. And this is not only for Indonesia, but it's also for malaria control as globally. This is the situation of malaria in Papua. The focus of malaria in Indonesia, about 90% is actually in Papua. Here we can see, let me show you. Here in Mimika, the annual parasite incidence is about 450 from 1,000 population, while in Kerom it's around 500 from 1,000 population. These are the areas where we have the highest number of malaria among other parts of Indonesia. And compared to Africa, where the predominant focus of age of malaria in Africa is in children, in Indonesia, malaria is related to job, and we can see that malaria usually occur in productive age group in adult and less in children. And while in Africa, falciparum is the dominant species of malaria, in Indonesia, we can see that the ratio between falciparum and vivax is actually quite comparable. The other concern that we need to focus is our friend from Army that came back from deployment from Papua. Majority of them will contracted with malaria, and some percentage also will be resulted in death. And when we look at the problem of malaria in Africa, the first slide that I show you, that the children has highest mortality due to malaria in Africa, but in Indonesia, actually the mortality in the first year is due to vivax, and that's because of the recurrences, and that will cause the severe anemia in children. This is the result of the study in Papua. So the proportion of malaria in children in Indonesia, especially in Papua, is due to vivax compared to falciparum. Dr. Inke has shown us this figure before. We have effective intervention to prevent malaria. There are specific intervention for non-infected individuals, such as vector control, chemoprophylaxis, and now we have malaria vaccine. And there's also some interventions for non-infected and infected individuals, such as chemo prevention, IPTP, or seasonal malaria chemo prevention, or mass drug administration. And for someone with disease, the early diagnosis and prompt treatment is the mainstay approach for the effective intervention. All these interventions will be effective if combined together. WHO has some strategies, actually, because we are committed to achieve malaria elimination in 2030. WHO has some strategies. I think Dr. Ajib has mentioned this, that reducing malaria case incidence and also mortality rates by 90% by 2030, and eliminating malaria in at least 35 countries by 2030, and preventing a surge of malaria in all countries that are malaria-free. And I think this WHO strategies is really in line with what our national malaria program has for elimination. And WHO also recommend some approach such as case management, vector control, malaria chemo prevention, mass drug administration, as well as vaccine that include malaria vaccine. And in October 2021, WHO has recommended the first World Malaria Vaccine, RTSS, with adjuvant AS01 that can be used as the prevention for malaria falciparum for children living in high malaria transmission area. And the pilot implementation program was rolled out between 2017 to 2023 in 3 different countries in Africa, in Ghana, Kenya, and Malawi. And then this is the plan for malaria elimination in Indonesia. We have this action plan, and our government is very committed to achieve malaria elimination in 2030. It divided into different regions and different strategy because we have very different endemicity, and Indonesia is very huge. Western part and eastern part has very different endemicity and has to have very different strategy for elimination. And what will be the challenges for malaria vaccine development? We are questioning why we just have this malaria vaccine launch recently. It's very difficult to have malaria vaccine. The research has been going on for 60 years, and we just have this malaria vaccine recently. This is all because of the parasite itself. It's very complex. It has more than 50,000 genes. It has multiple parasite stages, multiple strains, and high antigenic variation. And in terms of immune response, it's also stage specific. And when we use human challenge model, until now, we don't have a validated correlate of protection yet. And not to mention that the production and the development of this vaccine is very costly and little incentive only to the manufacturers because of the lacking of high income market, because the users of this vaccine will be the countries with malaria endemic countries, not the high income countries. So these were the hurdles that causing the progress of malaria vaccine. So this is actually some strategy for malaria vaccine. One of the strategy is to target the pre-erythrocytic, and then the blood stage strategy and the transmission blocking. For vaccine strategy that targeted pre-erythrocytic, because the plan is to target sporozoites and infected hepatocytes. By targeting these two sporozoites and hepatocytes, the aim is to prevent initial infection, and then later it will prevent clinical illness, and of course it will prevent the malaria transmission. And the vaccine that has the most progress development is in this strategy. We have RTSS and R21 that already recommended by the WHO recently. And then there's another strategy that using blood stage, which targets the merozoites and also infected red blood cells, which aims to prevent, of course, the replication and later to prevent the clinical illness and, of course, the malaria transmission. For this strategy, the most advanced candidate is RH5. It just finished the phase 2 trial and continue to phase 3. And then there's another vaccine strategy with transmission blocking. And this strategy targets the gametes and the ookinets with the aim to prevent infection in the mosquito by the malarial parasites. And the most advanced candidate so far is PFS to 30N, and still working on the phase 2. Actually, what we need, or what the ideal malaria vaccine is the combination of this strategy, but we understand that it will be very difficult. And the ideal malaria vaccine will be the one not targeted only one species of malaria, but also can combine like falciparum and vivax. But maybe that also still in the pipeline. This figure shows us that the malaria vaccine that still in the pipeline, currently there's about 36 vaccine and about 101 clinical trials actively in clinical development. And 2 vaccines has already received WHO pre-qualified and recommendation, which is RTSS and R21. And about 31 vaccines targeted falciparum and about 6 vaccine targeted Vivax. And majority of the vaccine use the pre-erythrocytic strategy, and the other use blood stage and sexual stage. And there are several vaccine platform where some use recombinant subunit, virus-like particle, and the other platform. And this figure showed the countries that run the clinical trials for malaria vaccine, but Indonesia is not included in this trial yet. This is the timeline of RTSS development. To have the RTSS approved by WHO, it's actually requires more than 30 years of development. It was the idea of having this vaccine was introduced in 1984. And then later in 1995, the clinical trial phase 1 started. And then in 2015, the end of phase 3 clinical trial, and we received the result of the clinical trial phase 3. And after that, in 2016, the WHO recommend for pilot implementation in several African countries. That's why the rollout of this malaria vaccine implementation started between 2017 to 2023 in 3 different countries in Africa. And then in 2023, WHO also recommends the use of R21. And in May 2024, WHO released the position paper that mentioning that the use of RTSS and R21 as a recommendation because it has quite moderate efficacy and quite good safety, but it only can work well if this should be blended into the other malaria control approach that already established. We can see from the result of the malaria vaccine implementation after 46 months of vaccine scale up, that the result was the vaccine is safe, and it significantly can reduce the mortality about 13%, and this really helps the children in Africa, and about 22% reduction of hospitalization due to severe malaria. And while having this vaccine, the community also still implementing the ITN use, care-seeking behavior, and uptake of other vaccines. So WHO recommends the use of malaria vaccine for the prevention of falciparum malaria only, because the aim of this vaccine is only for falciparum. And the targeted age is for children that live in high malaria endemic area. And this vaccine will be given in 4 different doses, starting from 5 months of age. And for area with seasonal transmission, so 5 doses of schedule should be used to optimize the impact. So the 2 recommendation of malaria vaccine that WHO use is RTSS and R21. So, this is not a very good result that both of this RTSS and R21 both has very quickly waning in efficacy. The highest efficacy that they have is in the first 6 months, but after that, the waning in efficacy is we can find is very quickly. Between RTSS and R21, the efficacy is around 50 to 60. The R21 is a bit higher because this vaccine use more circumsporozoites compared to the RTSS, and the adjuvant that its use is more immunogenic. But both are moderate in efficacy. And there's also some strategy in using for a malaria seasonal area. If we are using it just prior to malaria season, we can have higher efficacy that it can increase until about 70%. That's another strategy that we can do to increase the efficacy of the vaccine. However, the vaccine will only work very well if we combine it with the other intervention that actually established. And it's already stated by WHO in the position paper that they launched in May 2024. The vaccine is not like the really powerful method. It's an additional tools that should be blended into the other approach, such as factor control, ITN, IRS, or the chemo prevention, such as SMC or mass drug administration. This is the last slide that I would like to summarize for all of us, that it took about 60 years to have malaria vaccine because it's very difficult. The parasite is very complex. The immune evasion strategy and the lack of correlate protection that makes it very complex to develop the malaria vaccine. Both malaria vaccine that recommends by WHO that we have now, RTSS and R21, are safe and has moderate efficacy. However, it only can be used to prevent falciparum malaria in children who live in high endemic malaria transmission. For Indonesia, where we have the lower mortality of malaria, and most burden in children is actually due to Vivax. For now, malaria vaccine may not be needed. The highest impact of malaria vaccine could be achieved if we use it together with other malaria control strategies that already established. I think that's all from me. Thank you very much, Prof. Elsa.
Thank you very much, Prof. Ayodhia. It's very enlightening presentation about malaria vaccine development. Everyone give applause to Prof. Ayodhia. We learned a lot about malaria vaccine target, the progress, and the recovery vaccine so far. RTSS, ESA01, and R21. Also, they have also what's that? Winning efficacy. Is it right, Prof. Ayodhia? And
Yes.
Prof. Ayodhia summarized also that it need to be combined with other strategies. One of the interventions could be the vector control. Now we move to our third and final speaker of these sessions with Professor Dr. Indra Vythilingam that will share to us the challenge in vector control with regards to non-human primate malaria. So, hello, Professor Indra.
Hello, yes. Shall I share my slides?
Yes, Prof. Indra, I need to introduce you. Welcome to this presentation, Prof. Indra. Prof. Indra is from Faculty of Medicine, Universiti Malaya. So she is expert in medical entomology and have extensive experience in malaria research across the region. So, Prof. Indra, you ready for the presentation?
Yeah, I shall share my slide. Can you hear
Yeah.
me?
Please, please.
I should go on. Should go on full screen. Okay. Thank you, Prof. Elsa. Good morning, everyone, and I would like to thank the organizers for inviting me to present at this seminar. So today I will be speaking on challenges in vector control with regards to non-human primate malaria. Let me close this. Oh no. Okay, as you all know, malaria remains a public health problem, although elimination is in progress, as we had heard from the previous speakers. Countries in Southeast Asia are in the pipeline for malaria elimination by 2030. However, non-human primate malaria parasites are infecting humans, and this is a stumbling block to malaria elimination in the region. Now, as you can see in this map, all countries in Southeast Asia have reported cases of Plasmodium knowlesi, with the exception of, I think, Timor-Leste. Okay, and in this area, we also have the presence of the long-tailed macaques, pigtail macaques, and also the vector mosquitoes, mainly the leucospirus group of mosquitoes. Now, one thing I would like to stress here is that we not only have Plasmodium knowlesi, but we have other non-human primate malarias affecting humans in Southeast Asia. The first case of Plasmodium cynomolgi was reported from Malaysia way back in 2014. Then we had cases reported from Cambodia, they reported cynomolgi. From Sabah, they have reported Sarawak, and also from Indonesian Borneo, Kalimantan. They have reported Inuai, Fieldii, and Kutniai. From Aceh, Sumatra, West Java, they have reported Kutniai, cynomolgi, as well as Inuai. And in Pahang, we have found the presence of Plasmodium inuai. Now, Thailand is not left behind. Thailand has also reported cases of cynomolgi, inuai, and fieldii. Now, as you all know, there was a Danish traveler who visited Thailand and Malaysia, and when he returned to Denmark, he was ill and he was found to be suffering from Plasmodium cynomolgi. Now, we have also done we have done a study on archival blood samples that were collected for some other purposes way back in 2010. And now when we analyzed those samples by PCR, we found that all the species of non-human primate malarias were present in those cases. So when we talk about malaria elimination of the vector is unachievable, okay? We just cannot get rid of all the Anopheles mosquitoes, vector mosquitoes. It's just simply impossible. The depletion of parasites in human hosts, yes, this is possible. We can get rid of the parasite from human. We can treat them. We can take precautions. We can introduce control measures, and we can control the parasites in the human host. And that is how we have managed to eliminate malaria in many countries. Unfortunately, malaria is now a zoonosis. How are we going to eliminate the parasite from the macaques? This is a huge problem we are facing. And we know that if we have Plasmodium knowlesi, WHO will not give us malaria elimination status. And the non-human primates hosts are present everywhere. We have Macaca fascicularis, Nemestrina, Presbytes malolophus in Malaysia. They carry all these 5 simian malaria parasites. And there are also 2 other species of monkeys in Thailand. They have the stump tail, which is positive, and also the northern pigtail macaques. So this is one of the major problems with non-human primate malarias. Now, the main vector for the non-human primate malaria that has been established and incriminated is the mosquitoes belonging to the leucospirus group. And the leucospirus group is divided into 3 subgroups. It's very easy to determine the leucospirus group because the mosquitoes have got a white band on the tibiotarsal joint, the hind leg of the tibiotarsal joint. But unfortunately, this subgroup is, the leucospirus group is divided into 3 subgroups: Leucospirus, Hackeri, Riparis. And the leucospirus subgroup is again has 2 complexes, the leucospirus and the dirus. It is not easy to just morphologically identify the species. There are 5 of them in the leucospirus complex, and of these, 3 of them have been incriminated as vectors in Malaysia. Okay, these are also distributed in other parts of Southeast Asia. We have incriminated Balabacensis, mainly in Sabah and Sarawak, parts of Sarawak. Then we have Intralatus in Peninsular Malaysia and latens in Sarawak and in Peninsular Malaysia. And then the dirus. There are 8 species in the dirus, but so far 3 have been incriminated. Anopheles crescens and Anopheles dirus. Dirus mainly has been incriminated in Vietnam. And in Hackeri, we have got 2, Anopheles hackeri and Sulawesi, which have been incriminated, Hackeri in Malaysia and Sulawesi in Indonesia. So there are 3 species in the Riparis group, but unfortunately, so far, none have been incriminated as the vectors. So this is just to show you the distribution of the vectors in Malaysia. And we have found that these cases of Knowlesi are occurring in the Titiwangsa range in Peninsular Malaysia, where the vectors are present. And in Sabah and Sarawak, in Sarawak, it's more to the east coast, and same with Sabah. And Sabah, of course, on the western northern region also have got a lot of cases, which actually tie down with the vectors. Now, if we look at the biting time of the predominant vectors in this country, we find that the vectors are biting early and they are biting outdoors. So the main peak biting time is between 6 to 8 or 9, okay, depending whether it's Sabah, Sarawak, or whether it's Malaysia, Peninsular Malaya. So with these vectors biting early and biting outdoors, we have a problem with control methods. And when we do studies with the vectors for the non-human primate malaria, it is very important to do monkey-baited traps. We were very fortunate that 2 of our studies, which we did in the early part of 2005, 2006 to 2008, we were able to set up monkey bait traps. So we set up monkey bait traps at ground level, 3 meters and 6 meters. And then these monkeys, we place 2 monkeys per cage and then hoist them up into these mosquito nets, and then we sample the mosquitoes. Now, what we found was that the vectors were found biting in greater numbers between 21 and 1. That means between 9 p.m. and 1 a.m., they were peak biting time at 3 and 6 meters. And it is at 12 midnight that the gametocytes peak in the macaques. So the mosquitoes pick up the gametocytes from the macaques in the middle of the night, and when they develop into sporozoites, they bite humans in the early part of the night when we are outdoors and not protected. So if we look at the human bait and the monkey bait trap, you find, and the only mosquitoes that we incriminated here are in red, that's latens and crescens. And if you find monkey to human biting for latens is 1:1.3, which shows that it will either bite human or monkeys. But whereas when we look at crescens, it is 1:2.5, which shows that crescens are more attracted to humans compared to the monkeys. And although we found Mercaturi, Pujutensis, watsoni in the monkey-baited trap, none of these mosquitoes were positive. Watsoni doesn't belong to the leuco group, but it was found in monkey-baited trap and it is negative. The same with Anopheles cocci. Though Anopheles cocci was found in very high numbers in monkey-baited trap, none of them were positive. Now, all these results have been published So now what we do is we do blood meal analysis of mosquitoes to see what animals these mosquitoes are biting. And we have found that it is only the leucovirus group of mosquitoes. We have found Anopheles introlatus and crescens to be biting the macaques. The other Anopheles mosquitoes are biting humans and other animals. Now, if we look at the porous rate of the mosquitoes, it's very sad whether it is forest, farm, or village, and whichever species of these mosquitoes, the porous rates are very high. They're all above 50%, mainly 60 to 70% of the mosquitoes are porous. So when the mosquitoes are porous, we know that either control measures are not working or there are no control measures being instituted. And this is to show you the infection status of the mosquitoes. We dissect all our mosquitoes, okay, and we look for the infection in the midguts and salivary glands are examined. They are positive, then we proceed with PCR. Here are all the species of Plasmodium. M2, M3, M4 means that there are mixed species. So we have 2 species of various Plasmodium, or we have 3 or 4. So you see that the mosquitoes also carry a larger number of the species of malaria parasite. They don't just carry one species. They carry some of them. We have found as mixed infection have got 2, some have 3, some have even got 4. And of course, some people have worked on whole mosquitoes as well. But it is best, if you want to incriminate the vector for the first time, is to look for the parasite look for sporozoites in salivary glands. So you can see here that although there are more cases in Sabah and Sarawak compared to Peninsular Malaysia, the number of mosquitoes that we are finding is very high, and they are mainly positive for Inuai. So that's why I say that if we look for cases, we will be able to find cases in humans. And in Indonesia, there's been reports that they have found Anopheles sulawesi to be positive for Inuai. In Thailand, they have found Anopheles latens to be positive for the simian non-human primate malarias, as well as Hylobates, which is from the gibbons. And they have also found introlatus to be positive. In Vietnam, they have found Anopheles dirus to be positive for the NHPs, and they have also, so far I have seen only papers from Vietnam which have showed that dirus was positive in the same mosquito. They have found human and non-human primate malaria. So they have found Knowlesi and falciparum, or Knowlesi and vivax. Now, deforestation has caused a major problem. With deforestation, these macaques have moved from the forest to forest fringes and agricultural areas, farms, and plantations. So what has happened is that the leucovirus group of mosquitoes have also followed these macaques, and they have come to the forest fringes, especially in Peninsular Malaysia. Because in Peninsular Malaysia, when we had malaria, human malaria, we never used to come across these mosquitoes, the leucovirus group, but now we do find them. So people are getting infected when they move from the villages to farms and forests, and when they return, they are getting infected by the bites of these mosquitoes, which are biting in the early part of the night. Now, another interesting observation that has been published is that in India, the results confirm the presence of Fragile, Inuai, and Cynomogae in Macaca radiata. Additionally, they report for the first time the presence of human malaria parasites in falciparum, in Macaca mulata and radiata. And also in the Atlantic forest of Brazil, they have reported vivax and malaria in their macaques. So, what is happening? Now, we know that the mosquitoes are picking up the parasites from the non-human primates, and they are then transmitting it to humans. We are still not very sure whether human-to-human transmission is taking place because we don't see clustering of cases occurring. Mainly, they're all sporadic cases. But now what we are reading is that human malaria is being transmitted, is being found in macaques. So, primate malaria parasites spilling into human population and human malaria parasites spilling back into wild non-human primate population. If this is really true, it's really alarming. We need to actually work very hard to do something to control the non-human primate malarias. Now, how to control the vectors? Yes, indoor residual spraying was one of the first methods that was used to control malaria, human malaria in those days. DDT, 2 grams per meter squared. It was very effective. And in many countries in those days, they managed to eliminate malaria by spraying DDT. Then when mosquitoes refused to rest on the wall, then we went on to insecticide-treated bed nets. And we all know that insecticide-treated bed nets actually brought down the number of malaria cases. 68% of the reduction was, they say, due to the use of insecticide-treated bed nets. Okay. Now the mosquitoes have become smart. They are biting outdoors in the early part of the night. So how are we going to control these mosquitoes? Can we use insect repellents? Can we use DEET? Will people living in these areas agree to use these? And then now also there is meflotrine and transflutrin sheets that are available. And perhaps for human malaria, it's a very good a tool that can be used. It can be hung in houses and it will help to bring down the number of mosquitoes. At least mosquitoes would not enter houses. But what happens to the non-human primate malaria vectors? Where are we going to hang these? This is our big problem that we are facing. So perhaps we need to go back to the very early days when they were doing larval control. We have to perhaps switch there. And to do larval control, the leucospirus group of mosquitoes actually breed in small puddles of water, small pools left by hoof prints or the tire tracks that have been left. These accumulate and these mosquitoes are breeding there. But still, perhaps we have to use drones, and perhaps pyriproxyfen may be a good larvicide to be used because it is quite long-lasting. So, in conclusion, non-human primate malaria is a threat to malaria elimination since currently no effective intervention is available. And please remember, not only Nolacai, we have cynomolgi as well as P. inui. WHO will not certify a country malaria-free if cases of Nolacai occur. Evidence-based policy development. There is no targeted surveillance for zoonotic malaria. Current malaria policy should include zoonotic malaria. And we need new vector control policy. We need new control methods. And is there actually a spillback from human to macaques? This is very important. So I would like to end my presentation by a final message. Since it's World Mosquito Day, I would like to quote from Andrew Spillman, who said that mosquitoes are well adapted to very unstable, transient environment. They are the first organism in the first out of a newly created body of water. So mosquitoes are always going to be with us. We need to try methods to control them. I would like to thank you all for your attention. And I would also like to thank all the various grants that I got for this project way back from 2005 onwards, and all my students who have done work on this and who have graduated. And thank you very much.
Thank you very much, Prof. Indra. Thank you for sharing the whole result of your project. So impressive. So we know here that we not only have Plasmodium nulacai, but we have another one, Cynomolgi, Inu, etc. and also the coming from the Anopheles, what's that subgroup, Leucovirus subgroup? Is that right, Prof. Indra?
Yes,
Yeah,
it is the Leucus
yeah,
virus subgroup.
yeah. And then that's not easy to combat that because the mosquito bites early part of the night and it's become difficult situation how to control that
Yes,
factor.
true.
Yeah, yeah. So now we enter the question and answer session. So we have collected several interesting questions from the participants. The first questions is from Bapak Samsul to Dr. Indra.
Is the case if zoonosis occurs between non-human and human. You want me to answer this question?
Yes, yes, please,
Actually,
Prof.
one thing about the non-human like Knowlesi, these cases can be treated. They are susceptible to the drugs. The current drugs that are used for malaria, they are also susceptible to the non-human primate malarias. But one thing is that they must be, when a person is ill, he must visit a doctor and be diagnosed. If they are not diagnosed early enough, then the chances of people dying to non-human primate, especially Knowlesi, is there. So the thing is, if you see a doctor and they find that it's Knowlesi or malaria, you can be treated. Um, the drugs are effective. The current drugs are effective.
Yeah. Thank you, Prof. Indra. The next question, please. Mas Dedi. Yeah. You
Is
still have,
lava
yeah, the
Is
second question, Prof. Yeah.
lava-free index still a suitable indicator for addressing high burden of dengue in the region? Okay, now when we come to lava index, now we have actually done studies and we find that the lava indices is not really an effective indicator now. We have brought down the lava house index is about 2% in Malaysia, but our dengue cases are so high compared to what it was in the early 80s and early 90s. Now we are seeing thousands of cases with so low index. And what we have now found is that there is a strong correlation between the infected Aedes aegypti mosquito and dengue cases. And there is a simple method that you can collect the Aedes aegypti mosquitoes using sticky traps, and you can use the NS1 kit to detect the dengue virus in the mosquito. Once you have detected the dengue virus in the mosquito, you will know that 1 to 2 weeks later, you are going to see cases coming out. So it is a proactive method where you can tell people beforehand to take action. And even if they fall ill, then they know they are suffering from dengue, they can visit a doctor and they will not have to die of dengue. So that is what I feel, that it is more effective to use the adult control to collect adult mosquitoes and look for the virus using the NS1 kit, which is so simple to use.
Thank you very much, Prof. Indra. Now we move to the question for Dr. Inke. Okay. Yeah, Dr. Inke. You have question here, doctor. What are the routine blood test result correlation with malaria combined with dengue?
Yes, thank you, Prof. Elsa. Yeah, so yeah, I know that this can be tricky, like in areas that are endemic for malaria and dengue. And in most health facility setting, especially at the primary healthcare, like sometimes like the basic laboratory test is not available. But like as the complete blood count is routinely tested among patients with fever. So usually in malaria and dengue, we would see both thrombocytopenia, which is quite common to be found both not only in dengue but also is common in malaria. But of course, like for malaria, like using the blood slides, we could identify the presence of any asexual stages or also sexual stages, but we cannot really identified of dengue for dengue. Therefore, like the markers specific for malaria and dengue are still needed to confirm the infection. It depends on how long the fever is. For malaria, like we can use the RDT for malaria. And I think in Indonesia, we use both that can detect the HRP and also the Plasmodium LDH. And that can also help in identifying whether they are falciparum or Vivax infection. But for dengue, it depends on the duration of the fever. For the first 3 days, then it is recommended to test with NS1, but then later it is recommended to test with IgM and IgG anti-dengue. And Prof. Elsa, I would like to add the answers to the first question addressed to Prof. Elsa. I'm sorry, Prof. Indra, about the efficacy of about the not the efficacy, but the risk of critical illness of knowledge in humans. Not only that the antimalarial is still effective for the knowledge because like Plasmodium knowledge has not been exposed to most antimalarials that are available. Because like the monkeys are not being treated, so they are not exposed to any antimalarial, including chloroquine and sulfadoxine pyrimethamine. So they're actually effective to all, not only to artemisinin. But because like during the diagnosis, it is difficult to differentiate of Plasmodium knowledge with other malaria. So it is recommended to treat them with artemisinin combination therapy because of the similarities, especially by microscopy to falciparum and also to Plasmodium malariae. And second, there is a risk of severe malaria in Plasmodium knowledge. First, because we don't have immunity to Plasmodium knowledge because of the less exposure, and second, of the faster life cycle of Plasmodium knowledge every 24 hours that can cause more severe disease in Plasmodium knowledge infection. So I hope that can add some answers to the first question as well. Thank you, Prof. Elsa.
Thank you, Dr. Inke. And we have also one question for Prof. Ayodhia. I think it's about the efficacy of the vaccines, malaria vaccines against Plasmodium falciparum.
Yeah. Thank you, Prof. Elsa. Thank you for the question. I think I mentioned that in one of my slide. The vaccine that WHO recommend currently, which is RTSS and R21, is actually works only for falciparum, to prevent falciparum, and both consider have moderate efficacy, around 50% for RTSS and around 66% for R21, and the highest efficacy occur after 6 months. But the efficacy is quickly waning every 6 months, and after 2 years of the follow-up, the efficacy reduced to 30% after 2 years. But after 6 months, the efficacy is around 50 to 60% for both RTSS and R21 to prevent falciparum. I think that's all, Prof. Elsa.
Okay. Thank you, Prof. Indra, Dr. Inke, and also Prof. Ayodhia for insightful presentation and also thoughtful answer during the Q&A. So, ladies and gentlemen, still many questions actually remaining, but unfortunately, our time is limited. So, we appreciate your understanding and encourage you to continue the discussion beyond these sessions. Today's session gave us a comprehensive overview of the advances in malaria control and elimination. So from Dr. Inke, we learned about progress in chemotherapy from SCT, which is potent, but also now start to show resistance in Southeast Asia, but still potent in Indonesia. And also the other progress is about using ivermectin in combination with ivermectin. And from Prof. Ayodhia, we learned about the malaria vaccine development, which has been developed 60 years. It's quite a long time to develop this vaccine because it's very complicated. We have multiple targets, multiple species, and even though there is vaccines that already recommended by WHO, but we still waiting for the podium 5 vaccine because mostly in Indonesia, in Papua, the children get malaria 5 is it right, Prof? Ayodhia, yeah.
Yes,
And
Professor.
also we also have learned from Prof. About vector control related to non-human primate malaria. I think we have diversity not only in the Anopheles but also the Plasmodium zoonosis, and so we was that having all the challenges in combating the zoonosis malaria. And also we know that non-human primate malaria can potentially also slow down efforts to eliminate the malaria. I mean, the malaria elimination we cannot get the certificate if there is still zoonosis malaria. So I think it's will be our homework, not only for Malaysia, but also in Indonesia, I think. So thank you everyone for joining us today and for your active participation. We hope you found this session informative and inspiring. So enjoy the rest of the webinar and we look forward to seeing you in the upcoming session. Thank you.